Hello, everyone. I'm Dr. Manish Nagpal. It's a great pleasure to be a part of this VRSI Masterclass series, and I would be talking to you about fundus fluorescein angiography. It's an extensive topic, and I've divided into four different parts. The first one is the basics of fundus fluorescein angiography, which is this particular presentation. After that, we'll do a series on the fluorescein angiography in diabetic retinopathy, followed by vascular pathologies apart from diabetic retinopathy, and then a miscellaneous, including choroidal and macular pathologies. So let's start with the origin of angiography, a little bit of trivia. Basically, two medical students, Harold Novotny and David Alvis, who are working with John Hickam, a pulmonologist, they were studying oxygenation by visualizing the retinal circulation using the fluorescein dye. And they noticed that the lens emitting light through the Zeiss fundus camera and postulated that it might be fluorescence. They sent this submission at that particular time, uh, and it was rejected by Dr. Derek Whale, who was then the editor of American Journal of Ophthalmology. After that, Bascom Palmer's chair, Dr. Edward Norton, and a young Dr. Gass published seminal reports on the use of FFA in the evaluation of retinal disorders in 1960s. 8 years later, Dr. Derek Whale apologized for missing one of the greatest advances in ophthalmology. And that's how the journey of fluorescein angiography began. So basically, it's on the principle of luminescence. When light energy is absorbed by a luminescent material, free electrons are excited into that high energy state. And once these electrons decay into the lower energy states, equivalent energy is re-emitted. And when this energy is present in the visible spectrum, it's called luminescence. So how does this happen? Basically, when white light, and we have the white light which enters the eye, so we put a filter of blue, which is 490 nanometers, and so it converts that white light, blocks it, and then the blue light goes in. And when this light comes out, there is a barrier filter which is green, which is 530 nanometers. And then emitted fluorescence which comes out of it is captured on a device, which could be a film or a CCD, whatever, which is what comes through as fluorescence. And today's times, we just don't look at white light. We are using different types of cameras, which are SLO based, laser based. And so the way we interpret these do not require any filters, which we talked about. There, the laser beam is working on these wavelengths, and that's what excites the light which goes in laser beam, and then it comes out, and we can see the fluorescence. So there's a flash-based camera which we talked about, and there's a scanning laser ophthalmoscope which we use with with machines like Spectralis, Mirante, etc. And then there's a confocal SLO, which is even more precise and higher resolution, but uses the same laser-based technology. So what is the fluorescein dye? Basically, it comes in two, three different in different types of concentrations. 500 milligram in a 10 ml vial of 5% fluorescein, or it comes as a 10% in a 500 milligram in 5 ml, or a 25% fluorescein in 750 milligram. So the peculiarity about this molecule is that it's about 80% protein bound when injected, and that's what makes some of the fluorescence possible for us to study. When we look at the images as we go through the presentations, we'll realize its importance. So it's typically injected, but it can also be used orally, and it's especially this is done sometimes in children. And in children, because you don't want to inject at times, you just have them use a dose of 25 milligram per kg body weight, and you could dissolve it in maybe an orange juice or some liquid and give it. And the images are taken about 40 to 60 minutes after the ingestion. What could one expect with the fluorescein in terms of any side effects? Most common are the nausea, vomiting, pyrexia, which we prepare the patients for. Inadvertent arterial injection at times, which causes a localized thrombophlebitis or a local tissue necrosis. Orange, greenish color tinge of the skin and urine up to 24 hours, which you must always tell the patient because they get alarmed otherwise when they go back home. Rarely, there could be an anaphylaxis or a milder allergy to it, and so you should always be prepared to take care of that, or a vasovagal reaction, which can cause a shock or an MI. Rarely a nerve palsy or neurological problem, seizures have also been reported. So always an informed consent of the patient should be taken before the procedure. If possible, anesthetist backup should be there with a crash cart, which is there to manage any potential risks which we discussed. Are there any contraindications? Where an absolute contraindication is a known fluorescein allergy, which you could test by injecting a bit into the skin and waiting for a reaction at times. And relative are a renal failure, moderate to severe asthma, or a significant cardiac disease. In pregnancy and postnatal period, well, there's no report of a fetal complication, but it should be avoided in the first trimester. It is detected in breast milk, and so if at all it needs to be given, breastfeeding should be stopped for 96 hours after the procedure as a part of the protocol. So let's understand the fluorescein dynamics, and before that, go on to the blood-retinal barrier, because that's how the protein binding property of this dye would explain how it leaks in some ways and shows us some of the manifestations. So what is the outer blood-retinal barrier that you see here? Basically, there's an outer barrier and an inner retinal barrier. The permeable flow through the choriocapillaries and Bruch's membrane is there, which is how the fluorescein enters this plane. Major choroidal vessels are impermeable to the bound or free fluorescein, while the unbound dye escapes the fenestrated choriocapillaries. And that's how we see the fluorescence in this plane. The RP blockade, which is basically made of the retinal pigment epithelium or the zona occludens, they block any sort of a kind of a any kind of leakage happening through that, unless there's a pathology which opens them up. And when we go to the intact inner retinal barrier, there's an intact inner barrier normally, which has retinal capillary endothelial tight junctions, which play a major role in preventing any egress. Neither the bound nor free fluorescent can pass because of all these properties of the inner intact barrier. But once it's disrupted due to a pathology, all these pericytes, basement membrane, endothelial cells, they can all lead to a leakage, and both the bound and the free fluorescein can leak into the extravascular space. Now coming to the technique, one has to have the patient seated well, and of course they're on a chin rest and well focused. First you take the color photos as you desire on the patient, and take the pre-injection photos so that it also helps in controlling and detecting auto or pseudo fluorescence, which we'll just discuss what they are in a little while. You insert the butterfly needle and ensure that it's got an intravenous access. Start the timer from 0 and at the same time injection of the dye. Carefully note any dye extravasation which warrants immediate termination of the injection. The video is started. The first few seconds are quite crucial for some of the pathologies, especially when you look at early filling or feeder vessels at times, which we used to look in the past for a lot of SRNVMs. Capture FFA images after the start of injection after 8 seconds in young and 12 seconds in older patients. We continue to take photos every 1.5 to 2 seconds eventually. Follow the angiography plan, focusing on the target eye based on the pathology, and then, of course, the other eye eventually. After the FFA is completed, confirm lack of allergic symptoms and reassure the patient, and at the discretion of the physician, have the patient observe for any possible reactions to fluorescein if you find them. This is how the whole dye progresses in a normal angiogram that you see here. So the phases of angiography. Before that, we just need to see that it comes from the internal carotid arteries, and it partly goes through the short posterior ciliary to the choroidal circulation, which is a shorter, less tortuous route, and comes quicker here. And then the other part goes to the ophthalmic artery, central artery, and then into the retinal circulation eventually. So the normal arm retina time is what is calculated and looked for, especially for any filling defects or pathologies where there is where you are expecting some sort of a delay. So quick uniform filling of arterioles is there in young patients 10 to 12 seconds, older patients 12 to 15 seconds. A slow, patchy, incomplete filling of retinal vessels greater than 16 seconds can occur, and it could be in all these ischemic pathologies. So first is the choroidal pre-arterial phase that we call that. And there's this choroidal flush which builds up the patchy lobular filling of the choroid, and which is where it leaks the free dye from the fenestrated choriocapillaries that we had earlier looked at the barriers above. Then comes the arterial phase where it reaches the artery 10 to 12 seconds post dye injection, and the whole arteriolar filling occurs at this phase while the choroidal continues to fill. Then is the arteriovenous. From the artery, it goes into the veins, and this whole transition is taking place. The axial hypofluorescent strip, faster plasma flow near vessel walls where the cellular concentration is lower. And then comes the venous phase. And this is about 16 to 17 seconds normally. The maximal vessel fluorescence is about 30 seconds, and the complete filling of retinal veins occurs in this phase at this particular time. First pass of the fluorescein circulation completed by about 30 seconds. And then there's a late recirculation phase, which can be about 5 minutes, and the dye is absent from the retinal vasculature after 10 minutes. So there's this recirculation, dilution, and the elimination of dye, which the intensity of fluorescence decreases as these phases progress. So why is the fovea dark? So there are a few reasons for that. One is lack of blood vessels in the FAZ, which is the capillary non-perfusion zone that we call it, 400 to 500 microns. There are taller columnar RPE cells which have more melanin and lipofuscin, which is why the blocked background choroidal fluorescence is there. And of course, the high density of xanthophyll at fovea, which causes the blocked background choroidal fluorescence. The anatomical landmarks through which we interpret the abnormal fundus fluorescence. So we go step by step from the pre-retinal area, which could have epiretinal membranes or hemorrhages, tractions, to vascular layers of the sensory retina, where you look at the retinal vessel perfusion, plexus is superficial and deep, and then the avascular sensory retina, the OPL and the HFL, the intraretinal edema, exudates, detachment would manifest here. The RP, outer blood retinal barrier, where there could be proliferations, depigmentations, hyperpigmentations, RP detachments, and then the choroidal circulation, where there's choriocapillaries and the large choroidal vessels, and then lastly the sclera. So that's how all the layers build up. So how do we interpret what we see on the fluorescein angiography? Any abnormal lesion on FFA, first determine whether there's hyperfluorescence, there is more fluorescence, or there's hypo, which is less dark fluorescence. So the causes of hypofluorescence could be an optical obstruction, which is a masking or a blockage of normal fluorescein density. So here it could be pigment, it could be an abnormal material such as exudate, lipofuscin, or it could be blood, a hemorrhage which is blocking this area. Here is an example of how there is a pre-retinal hemorrhage which is there in front of the retina, in the pre-retinal space, subhyaloid hemorrhage, and it's blocking, as you see on the right side, the hemorrhage is blocking the vessels seen behind. So this is masking, this is a pre-retinal lesion. A large subhyaloid hemorrhage, you can see here, and on the fluorescein, everything is blocked in that area because there's a hemorrhage which is resting in front of the retinal plane and blocking all our view. Then there's masking of the background choroidal fluorescence. So here you see deeper retinal lesions, which are intraretinal hemorrhages, or subretinal lesions, which could be a subretinal hemorrhage. Now here you see that there is a subretinal hemorrhage. Here also there is sort of a masking, but then you can see that the retinal vessels are over that dark area. They are not in the subhyaloid hemorrhage. We saw that it was totally blocking everything. So this is in the subretinal space that you see this dark lesion which is there. So this is an example of a large subretinal hemorrhage, and here you can see also an OCT which is depicting the flow. And when you do the angiogram in this area, you can see that the vessels are seen over this dark space, unlike what we saw with the subhyaloid hemorrhage. And that's how you differentiate that. Apart from clinically seeing it, the FA can distinguish it very well. These are multi-layered hemorrhages in a Valsalva retinopathy. And you can see how the angiogram looks here, mass fluorescence partly, and there's a subretinal hemorrhage here. So this patient has both the aspects which are seen. There's a blockage over the vessels, retinal vessels, and under the retinal vessels. Then there's masking of the background choroidal fluorescence that you see here. So here you see that the increased density of the RP, which could be there with chirpy congenital hypertrophy of RPP, which you see here, or you see choroidal lesions like nevus, hemangioma, tumors could be there. Then there's inadequate perfusion of the tissue, which is either a vascular occlusion or loss of the vascular capillary, choriocapillary retinal bed, which is there. So you can see examples of these where there's total dark areas and you see junctions of perfused and non-perfused retina. And here you see the choroidal choriocapillaries, which are there, the bed of the choriocapillaries here. So when there's a vascular occlusion, it could be arterial, venous, capillaries, and you see here typically sclerosed vessels in the periphery, which correspond in the angiography to this dark area with a junction of perfused and non-perfused retina. This is with a chronic CRVO, ischemic CRVO, that this has happened in this particular case. A vascular occlusion of choroidal nature, where there is choroidal infarcts, very common in a lot of hypertensive patients. Sometimes you have these choroidal infarcts. In this, the choroidal hypoperfusion is caused by photodynamic therapy, verteporfin, that you see here. Loss of the vascular bed, choroidal vessels are exposed, and ground glass fluorescence of choriocapillaries at the borders of these patches are seen, very commonly seen with choroideremia or extensive myopic degeneration that this could be manifesting. Now we come to causes of hyperfluorescence, so increased fluorescence. So enhanced visualization of normal fluorescein density could be either a window defect, wherein there is lack of pigment, and what you're seeing is more choroidal flush coming just because the blockage, normal blockage is not there of the pigments. Or there's an abnormal vasculature that you see here. There's this tortuous, thick vessels, which is seen an abnormality of the vasculature in this network. The other thing is to increase fluorescein content of the tissues. So one is enhanced visualization we just saw, and then there's increased fluorescein. So it could be pooling, which sometimes happens with pigment epithelial detachments. There the intensity of the dye increases in the space, in the sub-RP space at times, but it does not increase in size. Leakage of the dye, when there's an actual leakage because of a pathology, it could be new vessels which are leaking, or diabetic retinopathy with all sorts of leaks that are there, or staining, where it's just a staining of various scars or lesions or sheathing that one could see this. So before we go ahead, we also should know these terms which we talked about earlier while looking at the filters and starting the angiography: autofluorescence and pseudofluorescence. What is autofluorescence? Autofluorescence absorbs the blue light and emits yellow-green light in a similar fashion to fluorescein, but weaker. So it is detected on standard fundus photography, white light-based cameras with the excitation and barrier filters both in place. While pseudofluorescence is a mismatch of filters, and you may see this if there is a filter mismatch which has occurred. So if you are using a white light based camera, this is something which could happen. It happens sometimes with old worn out filters, and it can cause that. But most of the SLO based cameras do not have this issue at all. So just to give you a few examples of the autofluorescence, here you see a macular pathology, bilateral dystrophy of sorts, and then this is autofluorescence where the dye is not injected, and you are seeing this sort of a pattern which is coming bilaterally. Or angioid streaks that we are seeing, this streaks which go from the disc and spread out, and we are seeing autofluorescence using an SLO-based camera, and you see these. Autofluorescence is a whole, extensive topic, and I'll not go into the details, just to give you an idea of what it is. And it's a great tool to document these pathologies and look at progression over a period of time without having to inject dyes. Let's come back to the window defect, which is basically an atrophy or absence of RPE, which is unmasking of the normal background choroidal fluorescence. That's what we call the window defect. Dry macular degeneration, geographic atrophy, a full thickness macular hole that you see here is a window defect, or RP tears that you see here are showing you a window defect on this. Very early hyperfluorescence increases in intensity and fades without changing size or shape. So the size would never increase because this is a window defect, a dormant pathology. This is just the example of the large RP tear that I was showing you in the earlier slide, and the OCT related to it as to how the rip has happened here, and the tear is manifesting and seen very well on the window defect that you see here. This is again to describe a window defect because of pigment remottling, presumed tenofovir toxicity, and you see this whole mottling which is seen very well across both the eyes when you do angiography in these cases. So the abnormal vasculature we can divide into 6 morphologic categories: tortuosity and dilatation, telangiectasia, aneurysms, neovascularization, anastomosis, or tumor vessels. So FA shows marked tortuosity and traction in the retinal vessels in epiretinal membrane, causing a macular pucker. You can see the enhancement of all these areas on fluorescein angiography. Although today we most of the times diagnose it on the OCT, but this just gives you an idea of how much distortion it causes to the fundus. And here you see the FA shows marked hyperfluorescence of the abnormal dilated retinal artery and vein in this AV malformation, which is seen much more enhanced in the angiography in correspondence to what you see in the clinical picture. So we come to pooling, which we were just discussing. It's basically RP has tight junctions, and once there's a space created there, a convex tight space, the dye pools here. So here it would increase in intensity as the dye proceeds, but it would not increase in size because it's a tight space, which would not increase in size, but just increase in intensity. And here, what you're seeing is again a pigment epithelial detachment, which is of course not increasing in size and is maintaining the breakdown of the outer retinal barrier, which is the tight RP space, which is there. Then you come to the leakage. So here there is loss of the junctions that we were discussing earlier in the barriers. And this happens very commonly in all vascular pathologies, most commonly being diabetic retinopathy, retinal vein occlusion, cystoid edema, papilloedema. A lot of pathologies where there's a leakage because the junctions have broken down and the dye would tend to leak. Fairly early hyperfluorescence increases in area and intensity, but not in a defined space for cystoid macular edema classically. And then there comes a breakdown of the inner blood retinal barrier, which is primary absence of the endothelial tight junctions, which happens with CNVM, proliferative diabetic retinopathy, many tumors, vascular anomalies, Coats disease, etc. You see fairly early hyperfluorescence increases in area and intensity that you see in all the angiograms associated with that. And then there's staining, which could happen with a drusen, fibrous tissue, exposed sclera, normal optic disc, which is there. This is a healed serpiginous choroiditis, which is showing staining of the disc and the chororetinal scars, which are there. So these were all the descriptions of how to interpret the fluorescein angiography. The take-home message pearls from the basics of fluorescein angiography is don't just look for what lesion is there where the angiogram lights up. Look for arm to retina time, delays which might be there, arterial filling delays, delay in the superior versus inferior vascular filling, leakage into the retina or vitreous cavity, pooling, which is leakage of the dye in a confined anatomical space, or staining patterns, which could be diffuse fluorescein into the tissue. So look for all these on the basis of hypo and hyperfluorescence that we just discussed at this stage. At the next series would carry the diabetic retinopathy. At this stage, I would end this particular talk with the basics, and I would like to thank Dr. Shraddha Srivastav my VR fellow who's helped me curate and collate this presentation, and all my other fellows and optometrists who helped capture a lot of these images which have come into the presentation. Thank you very much, and I'll go on to the next series for diabetic retinopathy after this.